Thank you, Cindy. So I was going to welcome, but you welcomed everybody for me. But thank you all for joining me to discuss this important topic, which is healthcare transition. And this talk evolved from transition in chronic kidney disease and has kind of expanded a little bit to include research and healthcare policies in transition, and also strategies for developing a transition program. I'd like to start off with a few acknowledgments. Thank you to my bosses, Dr. Cristiano, Dr. Boland, and Dr. Hidalgo for helping me to be able to work on this project, and also Maria Ferris at UNC for her mentorship, and then most importantly to our patients who every day inspire us to strive to do better and improve our healthcare provision. And let's see if I can figure out how to advance the slide. Okay, sorry. Okay, just a few disclosures. So, our challenge right now is in trying to care for a growing population of patients with complex health conditions that are not only surviving through childhood, but living decades longer than they have in the past. And our health systems, which initially were designed to respond to acute episodic illness, now have had to spend an increasing proportion of time and resources to care for these patients with chronic conditions. And our patients, along with having to deal with complex health conditions, also are receiving care at many different sites and from multiple different providers, and that puts them at risk for errors and for poor care coordination. So healthcare transition is the planned and purposeful movement of adolescents and young adults with chronic conditions from child-centered delivery systems to adult care systems, from the inpatient to the outpatient settings, and from subspecialty to primary care providers. Healthcare transition involves actually all patients undergoing transition across different sites of care, but is particularly important in our adolescents and young adults with chronic health conditions because of the complexity of coordination that's involved, because of their higher life potential, which means that the consequences of poor transition are more, and also because they have an added element of developmental transition. Transition of care often requires extensive, time-consuming coordination of information between healthcare providers, and this, even though the transition process begins in the pediatric setting, this is not just a pediatric problem. The CDC healthcare statistics reported that in 2000, there were almost 10 million children and youth with special healthcare needs, and about 500,000 of them every year turn 18 and graduate into adult medical settings. So the cost of poor transition or failed transition can be quite high, and it can include loss of productivity, severe early comorbidities, and premature mortality. If we look back at some of the research that's been done in different areas where there are youth with chronic health conditions, there was a retrospective study in childhood cancer survivors that showed that many of these survivors were living into adulthood but had many unidentified physical, mental, and neurocognitive deficits that impaired their employment opportunities. And so they recommended early screening and intervention. In the diabetic literature, KIPS reported a significant drop in the attendance at diabetes clinic in the 2 years following transfer to the adult clinic. They actually had a very high attendance rate, 94%. So you can imagine if we transferred those statistics to our clinics, where we're starting off already with a lower attendance rate, this decline that we would see after transfer. He did, however, report that in districts where the adolescents and young adults had the opportunity to visit and meet with the adult clinicians prior to transfer, they had a much higher attendance in the 2 years following. Somerville in congenital heart disease reported that the period of transition between pediatric to adult clinics was associated with a higher rate of premature and avoidable mortality or deaths. And in our own kidney literature, Watson has reported that in the year and a half following transfer to adult services, in one small study, 8 out of 10 kidney transplants failed, and 7 out of 8 of those cases were deemed to be avoidable failures. So if we look a little closer at kidney transplantations in our adolescents and young adults, actually they have very good short-term survival. If you look at the graph on the left, that's showing graft survival in adolescents and young adults for different types of organs. And the top 2 gray lines, the top one is living-related kidney transplants, and the second one is cadaveric transplants over time. And you can see that the graft survival rate at 1 year is excellent, above 90%, and comparable to better than that we see in our adult patient transplants. However, if we look to the right at some longer-term outcomes, you can see that in the pre-adolescent to adolescent age group, although the 1-year graft survival is still excellent, the 5-year graft survival at that time and age where they are transitioning drops abruptly. And a lot of that can be accounted for by noncompliance, transplant rejection, and transition-related adjustment issues. Okay, so if we look at pediatric dialysis, or ESRD in the US, the prevalence doesn't seem to be as much maybe compared to some other complex chronic diseases. However, there are many more cases of pediatric chronic kidney disease who have not yet started dialysis, and this is a rapidly growing population. Also, even though the pediatric dialysis population accounts only for about 1 to 2% of the total dialysis population, they require a much comparatively higher cost in terms of labor, time, and cost of care. One estimate is about $100,000 annually per patient for pediatric patients that are on dialysis. In 2005, in the state of North Carolina, over 400 children and young adults were identified with kidney failure requiring dialysis. We can look at hospital data on admissions of pediatric patients or discharges of pediatric patients with diagnoses of acute or chronic kidney failure to get a projection of what is going to be the growth of our population of CKD in adolescents and young adults. And between 2007 and 2009, in our pediatric hospital here, there were 37 discharges for pediatric acute or chronic kidney failure, and within the PCMH hospital systems at large, there was about 111. Average length of stay for these patients, if the kidney disease was the primary diagnosis, 7 to 8 days. If the kidney disease was a complicating factor, up to 18 to 23 days. And if we include primary or secondary diagnosis of renal failure, between 2007 and 2009, accounted for an average of 1/4 to 1/3 of the pediatric hospital market share. Since we became Vidant Hospital and the pediatric services began again offering dialytic services, we can see that there's been a huge jump in terms of the number of admissions to the pediatric kidney service and of pediatric kidney consults. 17 per month compared to 37 in a year, and 18% of those patients on average out of the 17, which is 3 per month, have diagnosed advanced CKD or ESRD. So I just wanted to present a few cases that we often as adult and pediatric practitioners see that involve transition-related issues. So this is a young woman, 25 years of age. She enters the adult nephrology services in her early 20s, already in advanced CKD, ESRD. She doesn't have very many previous records, or they're not accessible. And her diagnosis is unspecified hypertensive kidney disease with presumptive FSGS. We don't have a biopsy result to say for sure. She starts off on peritoneal dialysis, struggles along for the first 2 years, and then gets switched to Monday, Wednesday, Friday in-center hemodialysis after multiple complications. She also has multiple severe comorbidities, including severe secondary to tertiary hyperparathyroidism with her PTH greater than 4,000. And just so that we have a range, it should be between 150 to 300. Chronic noncompliance, severe depression. She often comes late to treatments, leaves early, is not compliant with the dietary recommendations, and refuses treatment for her depression and refuses parathyroidectomy. So this behavior leads to her being tagged with the label of being non-compliant, and that actually takes her off the transplant candidate list for which she was initially undergoing evaluation. She is not engaged with the staff. She does not communicate much with the dialysis staff or the providers. Between 2002 and 2011, she has multiple hospital admissions for many different reasons, including severe gastroesophageal reflux, peritonitis, sepsis, and over a period of 18 months, because of severe renal osteodystrophy, becomes debilitated from chronic pain, progresses from having to depend on a cane to using a wheelchair. In September of 2011, she suffers a pathologic hip fracture and is admitted to the hospital and unfortunately passes away from complications of her disease. This is a tragic case, and unfortunately, we see a fair number of these. This is not necessarily unusual. So some of the points that we can learn from this case are there are a lot of young adults that have pediatric onset CKD, and often the way they present to the adult setting is in kidney failure, fluoride kidney failure, or having a failed transplant. And often they may come with not very much transfer of records, so their underlying disease etiology may not be clear, and that can result in undertreatment of non-kidney related problems associated with the underlying disease. These patients may not have had much of a transition process and may not have developed mature coping strategies, and so often from the adult provider standpoint, they feel like they have a persistent adolescent mentality, which makes it difficult for the medical team to communicate with the patient. And in addition, often these youngsters come with parents that have been very involved in their care and are used to having a big say in the care. And in the adult setting, we may often find this to be the difficult or intrusive parent or caregiver. The other problem is that, in adult dialysis staff, it is very busy. This is a perception, but it's also a truth. On average, if you're in the adult dialysis setting, they may be caring for 33 to 45 patients per shift, 3 shifts a day, versus in a pediatric dialysis setting, there may be 8 to 15 patients, 2 shifts a day. So there's a big difference in terms of numbers of patients and the time that's available for staff to spend trying to assist one patient's adjustment. But it is still very important because, as we see, if we don't spend that time, if we don't invest in that patient, the outcome can be pretty poor. In this case, I think that there were also some divergent goals of care. The family and the patient may have had some goals of care that were different from the medical team, and there was not good communication and trust established, unfortunately. Staff in the dialysis unit, the adult staff, often don't feel comfortable and are not trained in dealing with developmental issues that may carry over for young adults. And in the adult setting, there is less accessibility to multidisciplinary services that are often offered in the pediatric setting. This is another case that presented to, or was referred to, the adult nephrology clinic. This is a 26-year-old with complex congenital heart disease, poorly controlled diabetes and hypertension, referred by her pediatric cardiologist in the adult congenital heart clinic for stage 4 CKD. Looking back through her records, you can see there have been multiple attempts at transfer of care. 2 years ago, she was actually referred to the general internal medicine clinic, and over a period of a year or less, she had several referrals actually and no-show to all of those. And then she was admitted in January to a local hospital with acute exacerbation of congestive heart failure. Around that time, she had a set of labs in the computer with a BUN and creatinine of 95 and 3.19, glucose of 290, and a potassium of 6.6. The last documented visit in the adult congenital heart clinic is December of 2011, and then apparently at that point she was referred to adult nephrology, did not show up for her initial appointment. So this is another case of failure of transition, and we can only look back and say where are the points that maybe things became a problem. I think that there was reluctance on the patient's part to move forward to adult clinics. Maybe she felt somewhat abandoned and therefore did not pursue follow-up, and then that may have contributed to disengagement from her medical care. She also did not later on follow up with her adult congenital heart clinic and obviously developed premature severe comorbidities. There was an opportunity to try to re-engage this patient when she was admitted at the local hospital, but unfortunately because of, we don't have transition coordinators who can identify and capture those people, that our opportunity was missed. And this patient is somewhere out there. We don't know how she's doing. This is a case that presented to the pediatric service. 16-year-old with a 2-month history of nausea and vomiting, admitted to the pediatric inpatient service for progressive unsteadiness, had a set of labs and is found to be in fluid renal failure. Was initially admitted to general pediatrics. Pediatric nephrology was consulted. They biopsied the patient, found that the patient had collapsing FSGS with extensive interstitial fibrosis. The patient was started initially on hemodialysis. He was discharged from the hospital to the adult dialysis unit because there was no pediatric unit available in that area under the care of the pediatric nephrologist. 2 to 3 weeks later, he had a change in his dialysis provider because that particular dialysis unit did not have pediatric adolescent-friendly policies for peritoneal dialysis, which is the modality of choice for young patients. And so over this 1-month period of time, this patient has had 4 transfers to different sites of care, 6 different electronic health records, none of which communicate with each other. And part of this problem is that there are non-integrated health records, and even within the same health system, sometimes the health records are not integrated. On top of that, we're dealing with an outpatient dialysis system that is adult-oriented and lacks the flexibility to accommodate for our adolescent patients. So we need to have people that are really advocating for these patients. This is a 40-year-old adult with congenital heart disease, followed by a pediatric cardiologist for about 40 years, and is referred to adult nephrology for elevated creatinine. And the referral form typically comes the patient's name, the reason for referral, and then after that says, see HealthSpan for notes. So you can see this is a case where there is transfer of care but without appropriate transfer of information, and you're sending a patient who has a 40-year history of congenital disease that the adult provider may not be familiar or comfortable with caring without a detailed transfer of information. And a nice transfer letter would have been a good opportunity also for the pediatric provider to engage the adult provider and to provide a little bit of education. And unfortunately in this case, the HealthSpan record does not include the pediatric records because they're in a different system called Centricity. So not only is it very difficult to mine data, but you have a lag of time in collection of information. Okay, so this is a little bit of a better case. You have a 20-year-old who is being managed by her outpatient pediatric rheumatologist for systemic lupus. She's had multiple admissions in the past to the pediatric service and now gets readmitted at the age of 20, again to the pediatric inpatient service for chest pain, and there's a concern that she might have ischemic heart disease. So what you have is an aging in the terms of pediatrics, young adult, in the pediatric hospital setting, pediatric hospital staff feeling uncomfortable with the continued care of this aging adult patient that might be starting to have adult issues. But fortunately, the pediatric attending happened to be a med-peds attending. She consulted the pediatric nephrologist, who actually happened to be a med-peds nephrologist, because the patient had an elevation in creatinine and proteinuria. And so they helped to coordinate the care. And for the following admission, the patient was seamlessly transitioned, well, seamlessly, we hope, to the adult inpatient services. And the patient also had outpatient follow-up with the med-peds nephrologist in her adult clinic. So here we, and then on top of that, the outpatient rheumatologist is also a med-peds provider. So just to demonstrate that if you do have transition specialists or people that straddle, this can really kind of help to coordinate your transition. It might not fix all of the problems, but it does make it a little bit better, and we can avoid the patient feeling abandoned, and you can have a more planned transfer rather than unplanned with no information transfer. So how many of you have heard these, coming out from your patients? We see this, we hear this a lot. This is actually from some studies where patients, families, adult providers, and pediatric providers, they all got together, kind of talked about their feelings regarding transition, and some of the more common comments were pulled together and published in this paper, and I've added a few of my own common ones. So a lot of the patient perceptions and family perceptions of adult care feel like it's too abrupt. There's little or no preparation for the visit, which may be that they didn't have any information transfer, or it could be also because the adult clinics are very busy and they don't have a lot of time scheduled for each patient. A lot of apprehension because of the feeling that the adult providers don't have a lot of experience with some disease processes, which may be true. We also get I get a warm, cozy feeling when I'm in the children's hospital, and that is not there when I'm in the adult setting. And we've also had parents come back and say, all of a sudden I go to the adult clinic, I can't get services for my child, what's going on? How about perceptions on the pediatric provider? Well, interestingly, a lot of the provider perceptions on peds is reflected in the patient perceptions. So we as pediatric providers have to be very careful, what kind of perceptions we're transmitting. So some of these are that the internist hasn't really adopted the idea of comprehensive care or specialty care that encompasses the patient's needs. That may or may not be true. I would say that a lot of my adult colleagues have adopted the idea of comprehensive care. However, they may be limited by the lack of ancillary service support and the lack of time. The adult provider doesn't have a whole lot of experience with patients with this disease. So this is reflective that we as pediatric providers need to do a better job communicating and providing some education on these diseases that span childhood. Our patients become like our kids. We get very attached and very protective. And that's certainly very true. And sometimes this perspective can get in the way of us facilitating the transition of our patients and the appropriate transfer of care. On the other hand, you also get the comments that, we feel like we just kick them out of the door rather than talking to them about it. And this shows that we know the transition process is not working, but yet sometimes we're still following the same transition process. And then finally, we're just across the street from each other, but it feels like there's a moat, a wall, and a couple of states and an army between us. How about from the adult side? I've heard actually quite a few of these. I never saw a patient with this condition before because they always died before they turned 21. I'm not comfortable with the growth and development issues. I don't have any records from the pediatric provider. I don't know what to do with all of these congenital problems. I don't think I could deal with the parents or the caregivers, or want to deal with the parents or caregivers. And again, the same perception that the pediatric and adult services are divided with an insurmountable barrier. So just to kind of sum up, beliefs and expectations and perceptions, sometimes those things can be true, sometimes not true, but they often can get in the way. Developmental factors, complexity of coordination, delayed or poor information transfer. Sometimes actually the supportive nature of pediatrics can foster dependence in our young adults and adolescents, which make it difficult for them to transition because they're not prepared. And also healthcare systems that lack support for transition. Okay, so now I guess everybody's feeling very overwhelmed. I think somebody said to me, if you could figure that out, you can get the Nobel Prize. We're not going to aim that high, but so where do we go from here? How do we start to approach the problem of transition and to fill in the gaps? And what strategies do we have? So actually, healthcare transition has been in the national subconscious for almost 30 years now. In 1984, there was a small conference addressing youth with chronic health conditions, and then 5 years later, the Surgeon General at that time, Everett Koop, convened a convention to discuss youth with chronic complex health conditions that were transitioning into adult medical settings. So this is really not a new topic, although sometimes it does seem like it is a new topic. In fact, 10 years ago, our primary care societies, the American Academy of Pediatricians, American Academy of Family Practitioners, the American College of Physicians, and the American Society of Internal Medicine jointly came out with a consensus statement supporting the practice-based implementation of healthcare transition for all youth beginning in early adolescence as the standard of care. And then subsequent to that, we've had some other things. One is annual leadership forum designating that transition in youth as one of the top 10 priority health needs. So unfortunately, even though we came out with this big consensus statement 10 years ago, in practicality, we have not seen the widespread institution of transition healthcare policies and transition programs. And in fact, although there are a lot of, position papers from individual programs and individual nephrologists, if we look at our own subspecialty guidelines from NTOCC, our national guideline distributor, or KDIGO, the international guidelines, not only are there no guidelines for transition is not even mentioned anywhere within those guidelines. So why has there been lack of practical advances? One is definitely there's a lack, we realize that it's a problem, but we have not established the infrastructure to support these programs. Many hospitals don't have policies or programs or have inconsistent policies. There's a lack of specialty-specific transition position statements. There's limited staff training in transition. There's often the lack of an identified staff person who's responsible for coordinating the transition, and limited programmatic funding and support. On top of that, you have anxiety from the patients, the parents, and the pediatricians to send them to adult care, and that inhibits us from properly preparing them. And also, we really have to work on engaging our adult colleagues and the adult medical systems, because this is going to be an increasing problem that we're dealing with in the adult arena. Some of the other system barriers that our patients face: age kind of discriminatory policies, which just means you turn 18, you're graduated, you move on. Now, we've tried to address some of those in the pediatric clinics now. The age has been extended to 22 to give them a little more leeway. Also, closed door policies: you've graduated, you don't come back. I think that's very difficult for the patients. They feel abandoned. There's not good transfer of information. Adult care systems, as we see, they're actually really organized to provide care for patients that are on average a lot older, so they can be somewhat inflexible, and these patients that have complex conditions require a lot more flexibility within the system. And then finally, I think that there's a low market value in terms of chronic health care. It's much more cool to be, in surgical services and to provide some acute care, whereas chronic health care often doesn't get properly reimbursed. So where do we go from here? There is hope for the future. We do have some strategies to try to make transition successful. We need to try to increase the market share of healthcare transition for our young adults and adolescents that have chronic kidney disease. We need to develop specialty-specific transition policies and guidelines. We need more hospital-based transition programs. We need to engage and educate our adult partners, and we need institutional reform. So our legislatures actually are a step ahead of us. So in the Healthy People 2010 goals, some of the points that are relevant to healthcare transitions, they emphasize increasing preventative visits by young adults, emphasis on information transfer and technology, and specifically improving transition in chronic kidney disease. President Obama signed the Patient Protection and Affordable Care Act into law in March of 2010. Unfortunately, since that time, there's been a lot of controversy and a lot of these things have not moved forward. But the intent behind that, part of the intent behind that was to try to address this gap in care. And there are 3 components that were aimed toward this. One is adult legislation in terms of healthcare coverage, PCIPs, or creation of pre-existing condition insurance plans, and the Patient's Bill of Rights. So just to elaborate a little bit more on that, so the actual statements expand adult coverage under parental plans. Sorry. See if I can postpone that. From age 23 up to age 26, and in some states up to age 29. In New York, you can be covered under your parents' health insurance plan up to the age of 29. In addition, you can be covered under the parental plan even if you've left the home, if you are working, even if you're working at a job where you're eligible for health care coverage from your employer, you still can elect to be under the parental health care plan. You can be married and still be covered under the parental health care plan. We may laugh, but if you think about this environment now, a lot of our young adults are coming out, they're not able to find jobs. The jobs that they find are low paying, and they may not offer very good insurance coverage. And so we're still relying, on our parents a lot of times. Another part of the plan was trying to address the pre-existing condition problems with insurance coverage. And the proposal was 2-stage. One was to establish specific insurance coverage plans that had reasonable premiums for patients that had pre-existing conditions. And the states were given a choice. They could either establish their own plan with federal funding, or they could allow the Federal Department of Human and Health Services to administer a plan. Our state elected to establish its own program. And then the second stage was actually elimination of all pre-existing condition clauses by 2014. And then the third part of this was the creation of healthcare exchange programs, which supposedly can provide affordable coverage to a wider sector of our population that may not have as high income level. A few other things that are covered under the Patient's Bill of Rights. Also ending the lifetime limit on coverage for patients that have chronic conditions. I remember in the past week or two, somebody was telling me about a pediatric patient who was in the hospital for a long period of time with many chronic conditions, and then on discharge they were told by their private insurance, we will never cover you again because you've already spent $2 million of our money. Restriction on annual dollar limits, trying to avoid the arbitrary withdrawals of insurance coverage where you can't quite figure out why the insurance coverage dropped you. Review of arbitrary premium increases to make sure that they're justified, and also protection of the patient's right of appeal. Okay. So in 2008, the National Transitions of Care Coalition identified several key components that they thought were necessary for a successful transition program. First being to be able to ensure the understanding and engagement of the patient and the care providers in the medical plan, clear ongoing communication among the members of the medical team and the patient, a multidisciplinary team approach and addressing not only medical issues but social, financial, and environmental factors that affect successful delivery and implementation of care. And again, transition should be planned, and it involves developmental stages. And so one way to look at this is sort of dividing up, the stages. In the transition process should start actually at the time of diagnosis of a chronic health condition. And at that time, what you want to do is to try to focus the parents on envisioning what is going to be the future for this child. Acknowledge that things are going to change over time, and have them try to address specific questions such as, what do you want for your child in terms of education? Where do you want them to be in terms of being a productive and independent adult? And that kind of sets the tone to let the parents know that through this process we need to be trying to work towards those goals. And then this is followed by the age of responsibility. As the child develops and becomes old enough, the practitioner should encourage the family to be teaching them about their disease process and to give them staged responsibilities. And then also, we as a medical team need to also engage the child and adolescent separate from the parents in their disease management. And before they go to the age of transition, that patient should have developed some level of self-efficacy. In age of transition, we should allow them to practice autonomy, coming into the clinics on their own if they're developmentally ready for that. Having them schedule their own appointments, having them schedule an appointment to go to the adult clinic to meet the adult practitioner and maybe to explore the adult care setting. And then also from the pediatric practitioners, appropriate transfer to the adult setting rather than trying to hang on to our patients too long. This is just a sample template of specific things that you might address with the patient and their families. Okay. I think the other component is realizing that the patient is the center, but this is actually a multi-systemic process, and that we need to recognize that there are multiple stakeholders and that systemic changes are needed in the underlying framework of the way that we deliver care. And some of those stakeholders are the pediatric hospitals, because they're having increasing numbers of aging young adults, and the adult services and care providers who are seeing adolescents and young adults with chronic conditions who need more extended ancillary services and more complex coordination of care. So this is my sort of initial perception. This is kind of our system as it is. We've got the pediatric subspecialists, the patient communicating with the patient and family, trying to communicate with the adult subspecialist, who's also trying to communicate back again. And then amongst all that, all the different factors that can affect transition issues. And what we would propose is to add a transition team with transitionists, a coordinator or multiple coordinators, and better systems interface to help strengthen these lines of communication between patient and adult and pediatric practitioner, and also to help us cover all of these other areas of communication, coordination, and education, because it's just so much to do that, sometimes it's above the ability of one person to do that, or even one practitioner and the nurse to do it. Okay, so elements again, in terms of care coordination, a transition specialist, either in the primary or subspecialty clinics or both. Transition clinics where you can have multidisciplinary visits where the adult and pediatric provider, sometimes it's multiple subspecialists, such as in the case of congenital heart disease, diabetes, hypertension, and kidney failure. A hospital-based transition coordinator, and more integrated health systems and records. Just to give you an idea of some of the multidisciplinary team members that might be involved. And what we envision would be the role of the hospital transition coordinator. Number one, to improve coordination of care transfer from the inpatient to the outpatient settings, to try to unify the different transition policies that might be developed from different divisions, and try to identify areas for cost, information, and labor sharing so that we don't all have to be repeating the same thing over and over again. To provide transition oversight outside of the individual divisions or subspecialties, to help disseminate educational material to the community and to the patients, and also to help us to benchmark our processes. And so to sum up, let's break down the barriers and let's get rid of the closed door policies and realize we have multiple stakeholders, try to engage in conversations and make care better for our patients. And